Hello, welcome to Pathagonia. This is Jay Huang. We hope you are doing well. We're going to talk about ovarian tumors using Kurt's Notes. If you already haven't been, check out Kurt's Notes websites. It's got amazing notes for medical students, pathology residents, and staff alike. And he has his About Me section as well as quizzes and useful links. Without further ado, let's talk about physiologic non-neoplastic lesions of the ovary. You have your cortical inclusion cysts. So you need at least focally tubal type epithelium. Other areas may have non-specific flattened cuboidal lining. It's commonly an incidental finding, usually in the cortex, and more common in older women. Size criteria-wise, it's less than 1 centimeter, and if it's greater than 1 centimeter, it's known as a serous cyst adenoma. Same thing, different sizes. Follicular cyst or follicle cyst. This is a cyst lined by uniform granulosa cells, which are often luteinized with outer thecal cells, usually give or take 4 centimeters, and almost always less than 8 centimeters. It's physiologic during reproductive age and likely due to abnormal pituitary gonadotropin secretion. Corpus luteum cyst. You have undulating, convoluted, thick, yellow lining composed of large luteinized granulosa cells. It's grossly yellow and filled with blood, and it's supposed to be greater than 3 centimeters to be a cyst. Pregnancy-related lesions. You have your pregnancy luteoma, which is multinodular hyperplastic proliferation of luteinized cells during pregnancy. Large solitary luteinized follicle cysts, which are large unilateral solitary cysts lined by luteinized cells occurring around pregnancy, and hyperreactio luteinalis. This is bilateral ovarian enlargement due to numerous luteinized follicle cysts related to pregnancy, and ovarian induction can result in similar changes. Now, this is a great schematic that Dr. Schaberg creates, and I really love it because first think about a pentagon, and you'll have your 5 categories of things we will cover. So basically, an ovary is made up of germ cells, an epithelial surface layer, and sex cord stromal cells. So if germ cells go awry, then you can get your pentagon of different main entities, including dysgerminoma, which is the seminoma equivalent in the females, choriocarcinoma, yolk sac, embryonal, and teratoma. And sometimes you can get mixed, and that accounts for 10% of ovarian tumors. 70% main source of tumors are your epithelial surface. So think about your surface tumors. When they go awry, they can become serous, endometrioid, clear cell, mucinous, and Brenner. And Brenner has nests of cells resembling bladder in fibrous stroma. Sex cord stromal makes up 15% of your ovarian tumors, and then there's metastasis going into the ovary, often from the GI tract, and that makes up around 5%. So serous, remember there's 2 pathways, low grade, which is driven by KRAS, BRAF mutation, and high grade, P53. Endometrioid resembles endometrial glands associated with endometriosis. Clear cell, also associated with endometriosis, and you have large clear cells with pleomorphic nuclei. And mucinous, where you have mucinous epithelium, and you want to rule out GI metastasis. So within these tumors, we're going to focus right now on the epithelial surface. Remember, we talked about the 5. And for epithelial surface subclassifications, you can classify them as benign, where they're known as whatever, mucinous, serous, endometrioid, cystadenoma, and adenofibroma if it's fibrotic. Then it's borderline, and if it's frankly malignant, it's carcinoma. Borderline tumors are neither clinically benign nor malignant. And you can have peritoneal dissemination and recurrence, but rarely death. And neither morphologically benign nor malignant. You can have architectural complexity, but no invasion or high-grade cytology. And there are differences in outcomes between borderline and carcinoma, and that's why when you gross, you must sample these really well, greater than 1 section per centimeter, to exclude a carcinomatous component. And we'll have this chart for your reference to review at another time. There are common mixtures of epithelial tumors, including Brenner and mucinous cystadenoma or borderline, serous and seromucinous borderline, endometrioid, and clear cell carcinoma. A note about seromucinous: this histologically exists, but it's likely not a true histomolecular entity that will eventually disappear, as it's likely composed of serous and endometrioid tumors. And here's another chart on stains for various epithelial ovarian tumors for your reference, but I want to highlight for high-grade serous, greater than 95% has P53 mutation. Low-grade serous, greater than 99% have WT1, but basically none have P53 mutation. Endometrioid, around 80% have PR. Clear cell, 95% have napsin A. And mucinous, 60% have P53, so that's where you want to rely on histology as well to make sure it's not a high-grade serous. Let's talk about epithelial surface tumors more in depth. Let's talk about serous. We'll talk about cystadenoma, adenofibroma, borderline, low-grade, and high-grade. So serous is fallopian tube-like, and it's thought to arise from either tubal metaplasia of cortical inclusion cysts, likely derived from surface mesothelium, or tubal implant. Serous cystadenoma, adenofibroma. Remember, this is like your cortical inclusion cyst, but it's greater than 1 centimeter in size. So you'll have epithelium resembling fallopian tube, as you can see here with your PEG cells. It'll be cuboidal to columnar cells. It'll be ciliated, sometimes stratified, but should have no hierarchical branching. And if you have a prominent fibrous component, you want to call it serous adenofibroma. If it's cystic, generally, then it's just serous cystadenoma. If it's both cystic and fibrous, you can be serous cystadenofibroма. And molecularly, it's typically polyclonal. It's not neoplasms, and It's a hyperplastic expansion of epithelial inclusions. Serous borderline tumor. This is seen in your middle-aged woman, typically around 50 years of age. And grossly, it'll be cystic with a papillary proliferation that looks like a cauliflower, often bilateral. It's non-invasive tumors with greater epithelial proliferation and atypia. You'll have hierarchical branching, where the papillae branch into progressively smaller papillae, like a tree, and epithelial tufting of columnar to cuboidal cells, and minimal to moderate cytologic atypia. Proliferative areas must be greater than 10% of your epithelial volume to call it borderline. Otherwise, you will call it serous cystadenoma fibroma with the caveat with focal epithelial proliferation. It's driven by KRAS and BRAF, and eventually it could progress to a low-grade serous, which is also driven by those mutations. It expresses ERPR PAX8WT1, it's P53 wild type, and P16 non-diffuse. And a borderline serous tumor can spread to peritoneum through implants. The prognosis depends on stage. If limited to the ovary, very good prognosis. If there are peritoneal implants, the risk of recurrence and potential progression to low-grade serous carcinoma. So because it can progress to low-grade serous carcinoma, you want to sample it well. Implants. This is extra-ovarian spread of a serous borderline tumor. It's often in the omentum peritoneum, where you'll have no destructive invasion nor high-grade cytology. You can have desmoplasia, which is reactive fasciitis-like, so a desmoplastic implant. These are mostly reactive fibrous tissue with scan admixed epithelium tacked onto the peritoneal surface. You want to ask yourself, is there fat or muscle invasion? Are there small solid nests of cells surrounded by a cleft-like space, micropapillae, and or cribiform growth? If so, then it's low-grade serous carcinoma, formerly called invasive implants. And if there's diffuse high-grade cytology, high-grade serous carcinoma. Serous borderline tumor, you can have the micropapillary cribiform subtype, aka non-invasive low-grade serous carcinoma. It has non-hierarchical branching architecture, and it has fine micropapillae that are 5 times taller than they are wide, coming off larger fibrotic papillae such that they look like Medusa's head. And sometimes these micropapillae fuse, leading to cribiform growth. And the cells are cuboidal with a high NC ratio, with often prominent nucleoli. And this component must be greater than or equal to 5 millimeters to make the diagnosis. And when it's low stage, it's the same outcome as serous borderline tumor. When it's higher stage, as expected, it's comparatively worse outcome. Low-grade serous carcinoma. These patients are about a decade younger than those who present with high-grade serous carcinoma. It's often bilateral and advanced stage. It most often arises in serous borderline tumors, and that makes sense because they are driven by the same mutations, this BRAF, KRAS mutation. And there are several patterns of invasion. You can have single infiltrating pink cells. You can have irregularly shaped infiltrative nests. You can have micropapillae and macropapillae surrounded by cleft-like spaces. And you can have frequent Samoma bodies, sometimes that it can even obscure the tumor, quote-unquote Samoma carcinoma. Cells often have moderate cytologic atypia, but less than 3-fold variation in nuclear size and rare nucleoli. Otherwise, you might consider it being a high-grade serous carcinoma. It has fairly uniform population of cells and low mitotic activity, 1 to 2 per millimeter squared, compared to high-grade serous carcinoma. And as mentioned, the mutations and IHC patterns are like your serous borderline tumor. Prognosis depends on stage, and it can go to lymph nodes. It does not respond as well to platinum-based therapy because it's less proliferative, because it has low mitotic activity compared to high-grade. And microinvasion is less than 5 millimeter in any single focus. Let's talk about high-grade serous carcinoma. This is the most common ovarian carcinoma, usually an older woman in their 60s, presenting with nonspecific symptoms at advanced stage, responsible for most ovarian cancer deaths. Often bilateral, solid, and exophytic, most commonly solid areas with slit-like spaces. Sometimes you can get papillary or cribiform architecture. You'll have lots of necrosis and mitoses. You'll have hyperchromatic pleomorphic nuclei with high NC ratio, often prominent nucleoli. If you get a TP53 stain, it will show remutation. About half have inactivating germline or somatic BRCA mutation. Lots of chromosomal and copy number change. So it'll be positive for WT1 and PAX8, variable positivity for ERPR, P53 has mutated phenotype, and P16 is block positive. BRCA1 and 2, you're at very high risk for high-grade serous carcinoma. So patients often will get prophylactic salpingo oophorectomy. And for us pathologists, we will do the CFIM protocol to better visualize the fimbriae, to better visualize stick, or the precursor for high-grade serous. So BRCA-related cancers, when they do get high-grade serous carcinoma, often have this set pattern where it stands for solid, endometrial-like, and transitional morphology, and lots of tumor-infiltrating lymphocytes. High-grade serous carcinoma, it's thought that most arise in the fallopian tube. So the normal tube, you get a P53 mutation, you develop stick or serous tubal intraepithelial carcinoma, and that develops into invasive high-grade serous carcinoma of the tube that spreads to the ovary. Essentially, it's tubal origin until proven otherwise. And you can only consider primary ovarian if both tubes are completely histologically examined and free of disease. If both tubes and ovaries negative, and you have high-grade serous carcinoma in the peritoneum, then it's primary peritoneal. And you want to treat with cytotoxic chemotherapy and often debulking staging surgery. So this is a great chart that Dr. Schaberg provides, differentiating low-grade serous carcinoma and high-grade serous carcinoma. And it's for your review, but I just like to highlight this high-grade serous carcinoma will have pleomorphic nuclei greater than 3 to 1. There'll be many more mites, greater than 12 per 10 high power field. P53 will be mutant, and it will be wild type in low-grade serous carcinoma. In low-grade serous carcinoma, it's driven by a BRAF KRAS mutation, and the precursor is thought to be borderline serous. High-grade serous is its own different ballpark, different mutation-driven, P53 and BRCA, and the precursor is STIC. And P16 for high-grade serous carcinoma will be block positive. Let's talk about mucinous. You can have your benign mucinous cystadenoma, adenofibroma. This is benign, usually unilateral. The average age is 50. It's grossly cystic or multicystic with a smooth surface, and it's arranged in glands and cysts. You'll have a single layer of mucinous epithelium, either resembling gastric or your foveolar type or intestinal with goblet cells. There's minimal atypia and only very rare mitoses. There's no epithelial tufting or broad papillae, and it's driven frequently by KRAS mutation, and adenofibromas, mucinous, are uncommon. And it can have a clonally related Brenner or dermoid cyst complex. Mucinous borderline tumor. This is a wide age range and arises from your mucinous cystadenoma. It's usually unilateral, multicystic with a smooth surface. It's lined by mucinous epithelium with mild to moderate nuclear atypia, but not high grade. And there will be architectural complexity, including epithelial tufting, stratification, villi, and papillae, as we can see here in these pictures. And the proliferative area, just like your serous borderline tumor, must be greater than 10% of epithelial volume. If there is high-grade cytologic atypia, then it's intraepithelial carcinoma. It's microinvasion if less than 5 millimeter of invasive carcinoma. And it can rupture, leak mucin into the stroma, and then you get pseudomyxoma ovarii. And you can have nodules in wall with atypical spindle cells and lots of mitosis, but CK negative, that's sarcoma-like mural nodules. And it's important to note because it can look scary, but it's a benign clinical course. And also, like your mucinous cystadenoma, it's driven frequently by KRAS mutations. Prognosis is generally very good, even with intraepithelial carcinoma, and still not bad with microinvasive carcinoma. It can progress to mucinous carcinoma, and thus must be sampled well to exclude an invasive component. If it is truly just borderline, subsequent transformation to carcinoma is rare. Let's talk about mucinous carcinoma. It is malignant. The average age is 55. Most tumors are confined to the ovary at presentation. It's unilateral, it's large, complex, solid, and cystic masses without surface involvement. And there are two main patterns of invasive growth that you need to know. Confluent expansile glandular growth with little stroma, and you'll have marked gland crowding with labyrinthine growth, and then destructive stromal invasion with infiltrating irregular glands, nests, and single cells in a desmoplastic stroma. And this pattern is less common, and if you do see it, you want to rule out a metastasis. It has increased cytologic atypia and mites than your borderline, and often exists on a spectrum with your concurrent cystadenoma and borderline components. You can have mural nodules with large atypical spindle to rhabdoid cells that react with cytokeratins and known as anaplastic carcinoma, in contrast to your sarcoma-like nodules in borderline tumors. If there is destructive invasion, but it's less than 5 millimeters in greatest dimensions, then it's microinvasion, and molecularly driven by KRAS mutations and CDKN2A frequently. And prognosis is often good prognosis. However, if it's advanced stage, then it's poor prognosis. This is a great table that differentiates the patterns of primary ovarian carcinomas versus metastatic mucinous tumors. And it's here for your review, but just to highlight the key points, primary ovarian, the laterality will be unilateral, whereas mets will be bilateral. And the size for primary will usually be larger, greater than 20 centimeters usually, and mets will be smaller, usually less than 10 centimeters. And the location for primary is within the stroma, whereas mets is within surface and stroma. And mets, if you see any signet ring cells, it's more likely than not that it's metastatic mucinous tumors. Okay, so this is a great IHC table for mucinous tumors and immunohistochemistry. And it's here for your review. It goes over ovarian mucinous borderline and carcinoma, ovarian seromucinous borderline, metastatic colon, metastatic gastric, and metastatic low-grade appendiceal mucinous neoplasm, or your lamin. And a good panel, Dr. Schaberg writes, is CK7, SAPB2, PAX8. CK7 will be strong in the ovaries, and SAPB2 will be strong positive in lower GI, but negative in ovaries, although it can be seen in ovarian tumors derived from teratomas. CDX2 of note is positive in most mucinous epithelium and is nonspecific as to GI versus gyne. And they both have similar mutation profile, both often have KRAS, BRAF, TP53, CDKN2 mutations. And PAX8 is helpful if positive, but isn't always positive in primary ovarian, where it's specific but not sensitive. In this table, Dr. Schaberg provides, adapted from a presentation by Dr. Ann Folkens, differentiates mucinous borderline tumors versus lamin. And Size is a big difference where primary will be larger, it'll be or more likely be unilateral, and pseudomyxoma ovary will be usually absent. Okay, let's talk about endometrioid epithelial tumors. So you can have an endometriotic cyst, aka endometrioma. This is benign, commonly and usually middle-aged. It's a cystic form of endometriosis. It's non-neoplastic. When you look at it grossly, it's what we knew in boards as your chocolate cyst. And it's composed of endometrial glands and endometrial stroma, often with hemorrhage and hemosiderin-laden macrophages, and it can undergo malignant transformation, where it can become endometrioid, clear cell, and seromucinous carcinoma. Endometrioid cyst adenoma adenofibroma. This is benign. It's a cystic lesion lined by endometrial glands without any endometrial stroma, and it's associated with endometriosis. And when you have dense fibrous components, then it's a adenofibroma, endometrioid adenofibroma. Likely just endometriomas in which the stroma is indistinct. Endometrioid borderline tumors. This is uncommon, seen in middle age. It's associated with endometriosis. It's usually unilateral, can be solid or cystic, or hemorrhagic. Architecturally, you'll have crowded or back-to-back endometrial glands with globular architecture lined by cells with mild to moderate cytologic atypia. It kind of resembles your endometrial intraepithelial neoplasia, your EIN. It can be papillary, protruding into cystic lumen. It can have mucinous or squamous metaplasia, but you should have no destructive stromal invasion and reconfluence or expansile glandular growth greater than 5 millimeters. The prognosis is excellent. Endometrioid carcinoma. This is malignant, usually in late middle age, often unilateral, low stage, and often associated with endometriosis, where it resembles your uterine endometrioid carcinoma, where you'll have this back-to-back glands with cribriform growth, these meandering glands that never seem to end, can have destructive growth, and you can have squamous morioles or differentiation, just like your endometrial cancer of the uterine. And you can have occasional mucinous metaplasia, and most previously diagnosed seromucinous carcinomas fall into this category. And it's driven by beta-catenin WNT pathway dysregulation, P10 inactivation, PIK3CA, ARID1A, and TP53 in high grade. And IHC, it's usually ERPR positive, WT1 negative, and P53 can be positive in high grade endometrioid. If ERPR negative, then you can consider Mesonephric-like carcinoma, which we will talk about later. The prognosis is good if low stage. Let's talk about clear cells. As Dr. Schaber says, the name says it all, with no normal counterpart. So clear cell cystadenoma adenofibroma. It's extremely rare. It's benign. It's associated with endometriosis. You have widely spaced simple glands and fibrostroma, cells clear to eosinophilic with bland nuclei, no mitoses. Clear cell borderline tumor, extremely rare. It's associated with endometriosis. It's round to oval glands and fibrostroma, clear to eosinophilic cells with moderate nuclear pleomorphism, mild epithelial layering, no invasion with stromal reaction, nor papillary architecture. You'll have infrequent mitoses and good prognosis. So your benign ones and borderlines are rare. Clear cell carcinoma is more frequent than those other two. It's malignant, older middle age, usually unilateral, solid to cystic. It's associated with endometriosis, and it's high grade, so there's no need to grade. So if you call it clear cell, it's high grade by default. Clear cell morphology, you'll have clear or eosinophilic granular cytoplasm, angulated pleomorphic hyperchromatic nuclei with prominent nucleoli. You'll have hobnail cells with varied architecture. It can be papillary, it can be tubulocystic, it could be glandular, or very rarely solid sheets. You can have hyaline globules and stromal hyalinization as well. And it's a low mitotic index, and molecularly, ARID1A mutation is the most common. Also, you can have PIK3CA, and it'll be positive for napsin A, HNF1 beta, as well as CK7 PAX8, but none of these are specific though, so rely on morphology most. WT1 and ERPR are negative, usually wild-type P53, and glycogen-rich cytoplasm is PAS positive, diastase sensitive, and the prognosis depends on stage, where the low stage behaves well. Your differential includes your germ cell tumors, of particular yolk sac tumor, where you'll have positive glypican-3, AFP, SAL4, negative CK7, another germ cell tumor, this germinoma, positive OCT3 to 4, SAL4, negative CK7, your other epithelial carcinoma, your serous carcinoma, positive WT1, often ER, default, diffuse or null P53, and another epithelial carcinoma, endometrioid carcinoma, positive ER, usually. Let's talk about transitional Brenner tumors. So it's transitional epithelium resembling your urothelium of the GU tract. So Brenner tumors, these are benign, often in older adults, but you can get it at any age, usually small, unilateral, solid, firm mass with small cysts. Architecturally, you're going to see nests of cells that resemble your transitional epithelium, urothelium. Kind of resembles like a Walthart's rest, but what makes it different is it's set in a dense fibrostroma. That's important to know. Mucinous differentiation can be common, and it can be seen with mucinous neoplasms, most commonly mucinous cystadenoma, as mentioned before, and calcifications can be common. It looks like urothelium, and it stains like urothelium too, where it'll be positive for P63, P40, CK7, GATA3, uroplakin3, thrombomodulin. Borderline Brenner tumor. This has a Brenner tumor with papillary areas resembling non-invasive low-grade papillary urothelial carcinoma. It'll have no destructive stromal invasion, often large cystic tumors. The prognosis is generally benign with some local recurrences, and malignant Brenner tumor. This is Brenner tumor with papillary areas resembling your invasive high-grade papillary urothelial carcinoma. You will have stromal invasion where you have irregular nests, confluent growth, marked cytologic atypia, and you need to see an underlying Brenner tumor. Otherwise, it's likely a serous carcinoma, which can sometimes have a transitional look, or a metastatic urothelial carcinoma. The seromucinous. So this is epithelium with both serous and mucinous appearance. Although this exists histologically, it is likely not a true histomolecular entity and will eventually disappear, or is likely composed of serous and endometrioid tumors. Nevertheless, it is in the WHO for now. Seromucinous cystadenoma adenofibroma. It's benign. It's rare. It'll be cystic with 2 or more Mullerian cell types, including mucinous and serous, less often also endometrioid, transitional, and/or squamous. Your seromucinous borderline tumor, usually younger in the 30s, unilateral, cystic tumor with smooth surface and inside papillary excrescences. You have non-invasive proliferative epithelial tumor containing at least 2 types of epithelium, most often 1, serous, and 2, endocervical type mucinous. And it can also include endometrioid, clear cell, transitional, and if those are present, you use the term Mullerian borderline tumor. You'll have complex papillary growth. Stroma is often edematous, and often lots of neutrophilic inflammation. And there are similarities with serous borderline tumor, where you'll have hierarchical and papillary growth, you can have dissemination of peritoneal implants, and can rarely progress to carcinoma. And differences from your serous borderline tumor is its strong association with endometriosis, lower malignant potential, morphologically resembles endometrioid tumors with mucinous metaplasia, little to no WT1 staining, and ARID1A mutations in many. And the prognosis is generally good, even with implants. Where seromucinous carcinoma is now a defunct diagnosis that is no longer used. Most cases were in fact endometrial carcinomas with mucinous metaplasia. Mesonephric-like adenocarcinoma. This is an adenocarcinoma with mesonephric-like differentiation. Architecturally, you'll have tubular, glandular, slit-like papillary and solid growth. It can have eosinophilic, colloid-like material, and it's dense to vesicular nuclei and frequently associated with endometriosis. IHC, it'll be positive for TTF1, where you usually think lung. GATA3, CD10, luminal, PAX8. It'll be negative for ER, PR, WT1, and have wild-type P50. Molecularly, frequently driven by KRAS mutations. Consider this diagnosis. If you have something that looks endometrioid, but is ER negative. Again, if it looks endometrioid, you get an ER, it's negative, think mesonephric-like adenocarcinoma. Differentiated and dedifferentiated carcinoma. Undifferentiated carcinoma is a malignant epithelial tumor lacking overt evidence of any specific line of differentiation. Dedifferentiated carcinoma, this is undifferentiated carcinoma with an abrupt transition to a dedifferentiated component, usually endometrioid. You'll have sheet-like growth, where you have geographic necrosis, high mitotic activity. It'll be monotonous, discohesive round cells with minimal cytoplasm. Molecularly, you'll have frequent loss of MMR proteins and/or SWI, SNF proteins, your ARID1A/B, and SMARCA4/A2/B1. And it's aggressive. Your differential is small cell carcinoma hypercalcemic type, which is seen in younger women. It'll be WT1 positive and almost always lacks your SMARCA4, BRG1. And we'll talk about that in a bit. Other entities are your carcinosarcoma, which is a biphasic neoplasm composed of a high-grade carcinomatous, usually high-grade serous carcinoma, and sarcomatous elements. Both components are usually P53 mutant. And mixed carcinoma, where you have ovarian carcinoma composed of 2 or more histologic types. Most common is endometrioid and clear cell carcinomas, of which both are associated with endometriosis as well. Now let's change gears and talk about sex-cord stromal tumors. A little variable, but often stained with some combination of inhibin, calretinin, SF1, FOXL2, melon A. Fibroma thecoma. This is a benign stromal tumor composed of bland spindled cells and fascicles with abundant collagen. Grossly, it'll be solid, firm, chalky white, and have varying patterns, including stored form to bundled to hyalinized plaques, usually in your middle age and unilateral. And if it's young and bilateral, and especially if lots of calcification, consider Gorlin syndrome or your nevoid basal cell carcinoma syndrome. Think about Meigs syndrome if you have fibroma, ascites, and pleural effusion, although this is relatively rare. And cellular fibroma is cellular with scant collagen, only mild atypia, and increased mitosis. Thecoma is a benign stromal tumor composed of sheets of uniform cells with pale grayish-pink cytoplasm. It's cytologically bland. Reticulin surrounds individual cells, to contrast to that from granulosa cell tumor. Thecoma is usually unilateral in postmenopausal women and often estrogen-producing. Grossly solid and yellow, as full of lipid and fat. Fibroma, fibrothecoma, and thecoma are like a spectrum. Your fibroma, where you'll have less cells and most collagen. Thecoma, you'll have the most cells and least collagen. And in between, you have your fibrothecoma. Sclerosing stromal tumor. This is benign. It's rare, usually in young women, and unilateral. You'll have bland, rounded, and spindled cells with eosinophilic to vacuolated cytoplasm. And you'll have the pseudolobular architecture, arranged in cellular nodules in a hypocellular edematous to collagenous background. You'll have dilated, thin-walled, branching, staghorn-like vessels. Scatat, or sex cord tumor with annular tubules. This is composed of aggregates of simple or complex annular tubules. The cells are columnar with clear cytoplasm with an antipodal arrangement of the nuclei, basically at opposite ends. And you'll have hyaline basement membrane-like material within the nests, and it occurs in two settings. One, sporadic, can have a low-grade malignant course, often unilateral, larger, set in fibrostroma, and more complex growth. Two, Peutz-Jeghers syndrome. It's benign, often incidental finding, often multiple, small, bilateral tumors with calcifications, set in normal ovarian stroma and a germline STIC11 mutation. Granulosa cell tumors. There are two types occurring in different settings with different prognoses. First, adult granulosa cell tumor. This is the most common sex cord stromal tumor. There's a wide age range, but often middle-aged. Usually unilateral, low stage, solid with some cystic hemorrhagic areas, and it secretes estrogen, and you'll have menorrhagia, or postmenopausal bleeding, and that can lead to, in the endometrium of the uterus, EIN. Cytologically, you'll have scant pale architecture with groovy nuclei, these coffee bean nuclei. You have varied architecture. It can be sheet-like, trabecular, ribbon-like, microfollicular, and you can have Cow-Exner bodies filled with pink secretions. An occasional macrofollicular architecture. IHC, it will be usually sex cord stromal stains plus WT1, FOXL2, some keratins, and others, and reticulin surrounds nests or groups of cells. Molecularly, the adult granulosa cell tumors driven by FOXL2 point mutations. For low-grade malignant, it can recur and even metastasize, even after long intervals, but not very common. Juvenile granulosa cell tumors. This occurs mainly in children and young adults, and less common. It secretes estrogen too, leading to precocious puberty, menorrhagia or amenorrhea. Cytologically, it'll be round with abundant eosinophilic cytoplasm and no grooves with vesicular chromatin. Architecture, you'll have macrofollicular with usually basophilic secretions and frequent mites. Molecularly, you will have no FOXL2 mutations. Prognosis is good with infrequent recurrence. Leydig cell tumor. Older middle-aged woman. It's unilateral and it secretes androgens leading to masculinization. Changes including hirsutism, amenorrhea, breast atrophy, clitoral hypertrophy, and horse. Cytologically, you'll see steroid cells with abundant pink granular cytoplasm. You'll have regular round nuclei with vesicular chromatin, and sometimes they may contain those rod-like eosinophilic crystals, Reinke crystals. And you can have fibrinoid necrosis of vessels and located in the hilus of the ovary. Sertoli cell tumor. This can happen at any age, usually younger, and it's unilateral, solid to cystic, and can be estrogenic. Very varied architecture. It can be tubular with or without lumens, trabecular, diffuse, alveolar, pseudopapillary, and you may see a few Leydig cells. Cytologically, these are cells with eosinophilic to pale cytoplasm and round nuclei with visible nucleoli. Usually benign, but can be malignant. It'll be positive for cytokeratins, WT1, sex cord stromal markers, and your differential is neuroendocrine tumor, which will be positive for synaptophysin. Sertoli Leydig cell tumors. This can happen at any age, often younger, solid, unilateral, and contains varying proportion of Sertoli and Leydig cells. The Leydig cell component secretes the androgens, leading to masculinization. Sertoli cell component can have varied architecture, varying degrees of differentiation, can have slit-like areas resembling reedy testes, quote-unquote rediform, can have heterologous differentiation, including mucinous epithelium. Molecularly, common mutations are DICER1. Germline DICER1 mutations, you'll have multinodular goiter, Sertoli Leydig cell tumors, pleuropulmonary blastoma, and prognosis for well-differentiated is very good, and steroid cell tumor. Usually in middle age, it's unilateral. It secretes androgens, usually estrogens, or corticosteroids, rarely. And cytologically, you'll have polygonal cells with abundant cytoplasm that is eosinophilic, quote, lipid poor, to vacuolated, quote, lipid rich. And it'll be round nuclei, no Reinke crystals like your Leydig cell tumor, and usually benign, but can be malignant if large, losomites, atypia, and or necrosis. Rare types, quote unquote, where the name says it all. Myxoma, a paucicellular tumor with extensive myxoid matrix, bland spindle cells, abundant capillaries. Signet ring stromal tumor, signet ring cells within a background of fibromatous stroma, lacks expression of EMA, absence of intracytoplasmic mucin. Microcystic stromal tumor, distinctive microcystic appearance. You have diffuse nuclear beta-catenin and cyclin D1. It'll be positive for CD10, WT1, FOXL2, SF1, negative for inhibin and calretinin. Luteinized thecoma associated with sclerosing peritonitis. Cellular spindle cell proliferation with luteinized cells typically associated with sclerosing peritonitis. Ovarian fibrosarcoma, overtly malignant fibroblastic neoplasm, and extremely rare. Gyandroblastoma, it's a sex cord stromal tumor with elements of both male, Sertoli cell tumor, and female differentiation, granulosa cell tumor. So we talked about sex cord stromal, let's talk about metastasis. Spread from extra ovarian sites, most commonly the GI tract, more often bilateral, especially hard to discriminate from primary for mucinous tumors. Signet ring morphology strongly favor a metastasis, especially Krukenberg tumor from the stomach or breast. Colon cancer is the most common metastasis and often has a distinctive look with dirty necrosis and a garland pattern of growth. After GI, breast is the most common. Now that we talked about sex cord stromal tumors, let's change gears and talk about germ cell tumors. These are, as expected, derived from germ cells, and because they're rapidly growing, Chemosensitive. Almost exclusively seen in young women and girls, and if there's greater than or equal to 2 malignant germ cell components, it is mixed germ cell tumor. Dysgerminoma, think clear or white color. It's the most common germ cell tumor. It'll be large, solid, fleshy, usually unilateral, and cytologically you'll have these large polygonal cells with clear to eosinophilic cytoplasm, distinct cell membranes, vesicular chromatin, and prominent nucleoli. You'll have fibrous septae and nested architecture. You can have lymphocytic infiltrate. Sometimes you can have granulomas. There'll be elevated serum LDH, rarely HCG. Molecular, majority have isochromosome 12p, and c-KIT mutations in many. Prognosis is good if treated. Embryonal carcinoma, think purple. Rare, rudimentary epithelial differentiation. It's high grade, large, primitive cells, vesicular nuclei with prominent nucleoli. You have coarse basophilic chromatin, amphiphilic cytoplasm, variable architecture where you can have nests, sheets, glands, and also molecularly isochromosome 12p. It's aggressive but responds to chemotherapy. Choriocarcinoma, think red color. In ovary, it's usually non-gestational and seen in young patients. You can get choriocarcinoma of note after a molar, ectopic, or normal pregnancy as well. But in the ovary, usually non-gestational. Histologically, you'll see malignant cytotrophoblasts, which are the mononucleated, and syncytiotrophoblasts, which are the multinucleated. You have abundant hemorrhage and necrosis. You have very elevated serum HCG, leading to precocious puberty, vaginal bleeding, or mimics pregnancy. Yolk sac tumor, think pink color. A endodermal sinus tumor, where you'll have grossly large, white, soft tumor with cystic degeneration. Architecturally, it can have many patterns in architecture. The most common is this reticular microcystic, but it can also be solid, papillary, and often has hypocellular myxoid area. If you see one, then you know it's a yolk sac tumor. It's the Schiller-Duval bodies. You can also have hyaline globules and now have elevated serum AFP. Teratoma, think rainbow color. This is composed of tissues from 2 to 3 germ layers. It's often cystic and unilateral. Common elements include skin with adnexal structures, cartilage, GI, brain, and it's associated with anti-NMDA receptor encephalitis. You can have mature teratomas, and this is exclusively mature tissue, and it's benign unless there's a secondary somatic malignancy that develops. Usually carcinomas like your squamous cell carcinoma or papillary thyroid carcinoma from struma ovarii. An immature teratoma, it often contains immature tissues, typically your primitive embryonal neuroectodermal tissues. These are mitotically active hyperchromatic cells with high NC ratios. They often have rosettes and neuroectodermal tubules. And grade is based on the amount of immature neuroepithelium below. Grade 1 is rare foci of immature neuroepithelium, less than 1 in 4x field on any slide. Grade 2 is 1 to 3 foci per 4x field on any slide. And grade 3 is greater than 3 foci per 4x field on any slide. And immature elements can mature to look like cerebral tissues with chemotherapy, even if spread to peritoneum, which is known as gliomatosis peritonei. Generally, good prognosis with treatment. And germ cell tumor IHC provides a great chart. If you're here for your reference, I would just want to highlight what he writes. OCT34 will be positive in dysgerminoma and embryonal carcinoma, negative for yolk sac and choriocarcinoma. CD30 will be positive for embryonal carcinoma, and glypican-3 will be positive for yolk sac tumor. Teratomas, you can have your monodermal teratomas, which is composed of only primarily one tissue type. Struma ovarii is mostly or all benign thyroid tissue. Carcinoid resembles well-differentiated neuroendocrine tumors of the GI tract, and is considered a type of monodermal teratoma, and when combined with struma ovarii, it's struma carcinoid, and has a good prognosis. You can have neuroectodermal type tumors, which are primitive tumors with variable neuroectodermal differentiation, resembling brain tumors like your medulloblastomas, and a stain-like brain counterparts. Miscellaneous. Small cell carcinoma of the ovary, hypercalcemic type. You'll see this in young women. It's unilateral, associated with perineoplastic hypercalcemia. Architecturally, it's an undifferentiated tumor with diffuse growth. Cytologically, you'll see small monotonous cells with scant cytoplasm, often focal macrofollicle-like spaces, and there's often a component of larger cells with more cytoplasm and rhabdoid morphology. Staining-wise, it'll be diffuse WT1, focal CK, EMA, loss of BRG1. Molecularly, it'll have a SMARCA4 mutation. It's very aggressive. Small cell carcinoma, pulmonary type, as the name implies, it's like the lung, so must exclude a metastasis. Seen in older women, often bilateral with extra ovarian spread, advanced like in the lung. A diffuse growth of small cells with scant cytoplasm, salt and pepper chromatin, and molding. There's lots of mice and apoptotic bodies, and it's poor prognosis. Gonadoblastoma contains a mixture of immature sex cord cells and germ cells. It's predominantly in young women with gonadal dysgenesis. It's not uncommonly bilateral. You have a sex cord component, which is scatat-like with nests with hyalinized basement membrane materials and lumens, and a germ cell component, often dysgerminoma-like germ cell neoplasia in situ. This good prognosis, essentially it's an in situ lesion like germ cell neoplasia in situ in the testes. Adnexal tumors, lesions, can have Walther's rests. These are common, incidental, nests of transitional epithelium. They shouldn't have a very overtly fibrotic stroma like in your Brenner tumor. Adrenal cortical remnants, you have round nests or cords of pale lipid-rich cells resembling the cortex of the adrenal glands, incidental finding. Paratubal cysts, Cystic structures around fallopian tube, lined by ciliated to cuboidal epithelium, very common. If greater than 1 centimeter, it's serous cystadenoma. Reactive inflammatory changes, salpingitis ismica nodosa, which is the diverticulosis of the fallopian tube with associated smooth muscle hypertrophy, and tubo-ovarian abscess, where you'll have a fibroinflammatory mass involving the fallopian tube or ovary, often secondary to pelvic inflammatory disease after upper genital tract infection. Wolffian tumor, aka female adnexal tumor of probable Wolffian origin, or FATWO, is often unilateral, older woman and solid. It's well circumscribed, often in adnexa, but distinct from ovary, especially broad ligament. You have variable patterns like sieve-like, retiform tubules, or solid. Cytologically, you'll have cuboidal to columnar cells, but lining cells may be flattened, and bland nuclei. It may have prominent hyalinized bands or eosinophilic secretions. It'll stain for cytokeratins, bimentin, CD10 luminal, and androgen receptors, be positive/minus for sex-cord stromal markers, and negative for ER, EMA, GATA3, PAX8, and TTF1, as opposed to mesonephric-like carcinoma, and it's usually benign. Miscellaneous tumors, leiomyoma, it's benign smooth muscle tumor, usually we associate it in the uterus, but you can have it in the ovary. You have adenomyoma, which is a benign admixture of endometrial-type glands with or without endometrial stroma and prominent smooth muscle. Adenomatoid tumor has variably sized slit-like tubular and cystic spaces lined by mesothelial cells. So if you stain with like D240 and other mesothelial markers, it'll be positive, and it's benign. Papillary cystadenoma. This is a benign papillary cystic tumor of probable mesonephric origin. It's minimal, clear to eosinophilic cytoplasm. It's non-ciliated and associated with von Hippel-Lindau syndrome. High-grade serous carcinoma. This is high-grade carcinoma with serous differentiation. It's identical morphology to an ovary. STIC. This is the precursor for high-grade serous carcinoma. It's called serous. It stands for serous tubal intraepithelial carcinoma, and usually found at the tuboperitoneal junction at the fimbriae, hence why pathologists do the CFIM grossing protocol. There's high NC ratio, nuclear enlargement, pleomorphism, hyperchromasia, loss of cilia and polarity, lots of mitoses. Even though it's intraepithelial, it can still metastasize and spread to the ovary and peritoneum. So it's essentially still malignant, and it'll be P53 mutant with high P67, greater than 10%. And you have increased risk if you have BRCA mutation, and that's why you get the prophylactic bilateral salpingo oophorectomy, which is entirely submitted. And then you have an entity called serous tubal intraepithelial lesion. It's atypical, but just falls short of criteria for STIC. And this is just a criteria for assigning a primary site of extrauterine high-grade serous carcinoma. Basically, the most common one is fallopian tube, where you should have STIC present or mucosal high-grade serous carcinoma present, or part or entire length of tube inseparable from tubo-ovarian mass. And I'll leave these for your review. And thank you so much. If you came with me to all the way to the bottom, I appreciate you going along the journey with me. A big shout out to Dr. Schaberg for his excellent notes. Rapid recall: ovarian tumors, they're physiologic lesions, cortical inclusion cysts, tubal-like epithelium, less than 1 centimeter, otherwise it's serous cystadenoma, follicle cysts, uniform granulosa cells, which are often luteinized, usually 4 centimeters, corpus luteal cysts, grossly yellow, filled with blood, luteinized, large granulosa cells, greater than 3 centimeters, pregnancy-related lesions, pregnancy luteoma, large solitary luteinized follicle cyst, and hyperreactio luteinalis. Ovarian tumors, think germ cell, there's 5. Germ cells make up 10%. There's 5: dysgerminoma, choriocarcinoma, yolk sac, and brinal teratoma. Sometimes they're mixed. 70% of ovarian tumors are epithelial. And think about your 5: Brenner, Serous, Endometroid, clear cell, Mucinous. Sex-cord stromal make up 15%, and Mets make up 5%. Epithelial can be cystadenoma, borderline, or carcinoma. For serous cystadenoma, it's basically like a cortical inclusion cyst, but it's greater than 1 centimeter. Serous borderline tumor, it looks like cauliflower. You have hierarchical branching, epithelial tufting, greater than 10% of epithelial volume, driven by KRAS BRAF mutation, ERPR PAX8 WT1 positive, and it can spread to the peritoneum, and it's known as implants. Implants can have desmoplasia, but there should be no destructive invasion or high-grade cytology. Serous borderline tumor with micropapillary or criviform subtype, you have fine micropapillae 5 times longer than they are wide, look like Medusa head, and this component must be greater than or equal to 5 millimeters. Low-grade serous carcinoma, frequent psammoma bodies, single infiltrating pink cells, infiltrated nests, surrounded by cleft-like spaces, often arises in serous borderline, low mitotic activity, high-grade serous carcinoma, most common ovarian carcinoma, solid areas with slit-like spaces, lots of mites, lots of necrosis, lots of hyperchromasia, pleomorphism, driven by TP53 mutation, WT1 PAX8 positive, variable ERPR, and P16 block positive. And if you have BRCA, you're at very high risk for this, and it originates from the fallopian tube. Mucinous cystadenoma, benign, arranged in glands and cysts, single layer of mucinous epithelium, gastric or intestinal, minimal atypia. Borderline, mucinous borderline tumor, you'll have architectural complexity like epithelial tufting, stratification, villi, and papillae. You can have mild to moderate nuclear atypia. and it must be greater than 10% of epithelium volume. You can have nodules in wall with atypical spindle cells and lots of mites that are CK cytokeratin negative, and those are sarcoma-like mural nodules, benign clinical course, frequent KRAS mutation. Prognosis is generally good. Mucinous carcinoma, two patterns of invasive growth, confluent expansile glandular growth, and destructive stromal invasion. Usually unilateral, it's unilateral, large, and you can have mural nodules with large atypical spindle to rhabdoid cells that react with cytokeratin and, quote, anaplastic carcinoma, and driven by KRAS mutations and CDKN2A frequently. Endometrioid, you can have endometriotic cysts, where it's a cystic form of endometriosis where you have glands and stroma. Endometrioid cystadenoma, adenofibroma, it's endometrial glands without any endometrial stroma. Endometrioid borderline tumor, it's associated with endometriosis, it's uncommon and resembles EIN. There should be no destructive stromal invasion or confluence or expansile glandular growth greater than 5 millimeters. Excellent prognosis. Endometrioid carcinoma associated with endometriosis resembles endometrial carcinoma of the uterus, where you'll have cribriform growth, meandering glands, you can have squamous morioles, you can have mucinous metaplasia. ERPR positive, WT1 negative, P53 can be positive if high-grade endometrioid. If ERPR negative, but cytologically it looks like endometrioid, consider mesonephric-like carcinoma. Clear cell cystadenoma and borderline tumors are very, very rare. A clear cell carcinoma is malignant, it's high grade by definition. You'll have clear or eosinophilic granular cytoplasm, pleomorphic hyperchromatic nuclei, HNF1b and napsin A positive, WT1 and ERPR negative, usually wild type P53. Transitional, Brenner tumor is benign. It has transitional epithelium set in dense fibrous stroma. Mucinous differentiation can be common, and it's positive for P63, P40, CK7, GATA3, uroplakin-3, thrombomodulin. Borderline Brenner tumor with papillary areas resembling non-invasive low-grade papillary urothelial carcinoma without destructive stromal invasion. Malignant Brenner tumor, papillary areas resembling invasive high-grade papillary urothelial carcinoma. Stromal invasion will have irregular nests, confluent growth with marked cytologic atypia, and you need to see an underlying Brenner tumor. Otherwise, you want to think about serous carcinoma or metastatic urothelial carcinoma. Seromucinous, epithelium with both serous and mucinous appearance. Seromucinous cystadenoma or adenofibroma, it's benign, it's rare, cystic with 2 or more Müllerian cell types, including mucinous and serous. Seromucinous borderline tumor, it's non-invasive proliferative epithelial tumor containing at least 2 types of epithelium, most often 1 serous and 2 endocervical type mucinous. You'll have complex papillary growth, often neutrophilic inflammation. It has similarities to serous borderline, including hierarchical and papillary growth and peritoneal implants. Different from serous borderline tumor, however, is its strong association with endometriosis, lower malignant potential, and morphologically resembles endometrioid tumors with mucinous metaplasia, little to no WT1 staining, and ARID1A mutations in many. Seromucinous carcinoma is a defunct diagnosis that is no longer used. Other entities, mesonephric-like adenocarcinoma, you'll have tubular, glandular, slit-like papillary and solid growth, can have eosinophilic colloid-like material frequently associated with endometriosis. It'll be TTF1, GATA3, CD10, luminal positive, and Paxate. It'll be negative for ERPR, WT1, wild type P53. Undifferentiated and dedifferentiated carcinomas. Undifferentiated is we don't know the specific line of differentiation. Dedifferentiated has an abrupt transition from a differentiated component, usually endometrioid, to an undifferentiated. It'll have sheet-like growth and frequent loss of MMR proteins and or SWI-SNF proteins. Carcinosarcoma and mixed carcinomas. Carcinosarcoma, biphasic neoplasm with high-grade carcinomatous, usually high-grade serous and sarcomatous elements. Both usually have P53 mutant. Mixed carcinoma has an ovarian carcinoma composed of 2 or more histologic types. Most common is endometrioid and clear cell carcinomas. Sex-cord stromal will be positive for generally inhibin, calretin, SF1, FOXL2, melon A. Broma is the most common ovarian stromal tumor. Benign stromal tumor has bland spindle cells and fascicles with abundant collagen. Chalky white, if young, bilateral, and lots of calcifications, considered Orlin syndrome. Thecoma, benign stromal tumors composed of sheets of uniform cells with pale, grayish pink cytoplasm, often estrogen producing, grossly solid and yellow. Sclerosing stromal tumor, it's rare, it's seen in young women. You have a pseudolobular architecture and staghorn vessels. Scatat, sex-cord tumor with annular tubules. You have hyaline basement like membrane-like materials. Cells have clear cytoplasm. It can be sporadic or it can be associated with Peutz-Jeghers syndrome, germline stick 11 mutation. Granulosa cell tumors, 2 types. Adult granulosa cell tumors have the grooved coffee bean nuclei and have Cow-Exner bodies and FOXL2 point mutations. Juvenile granulosa cell tumors have no grooves. It has no FOXL2 mutations. Leydig cell tumor, it'll lead to androgen secretion and masculinization. You'll have abundant pink granular cytoplasm, and you can see Reinke crystals. Sertoli cell tumor, any age, usually younger. Variable architecture, you'll have eosinophilic to pale cytoplasm and round nuclei with visible nucleoli, usually benign, but can be malignant, and it's positive for cytokeratin, WT1, sex-cord stromal markers, and your differential is neuroendocrine tumor. Sertoli Leydig cell tumors, you have varying proportions of Sertoli and Leydig cells, and Leydig cells will be the ones secreting the androgens, leading to masculinization. Molecularly, you want to think about dicer1 mutations. Steroid cell tumor, these secrete androgens usually, estrogens or corticosteroids rarely. You have polygonal cells with abundant cytoplasm, but it won't have Reinke crystals, and usually benign, but can be malignant. And rare types we talked about are myxoma, signet ring stromal tumor, microcystic stromal tumor, luteinized thecoma associated with sclerosing peritonitis, ovarian fibrosarcoma, and gynandroblastoma. Metastasis, most commonly from the GI tract. If you see signet ring morphology, that strongly favors a METS. The most common metastasis is colon cancer. Germ cell tumors, dysgerminoma is the most common. Large polygonal cells, nested architecture, lymphocytic infiltrate, good if treated. Isochromosome 12p looks white. Embryonal looks purple, high-grade, large primitive cells, vesicular nuclei with prominent nucleoli, isochromosome 12p. Choriocarcinoma, think red. An ovary, usually from non-gestational. You'll see malignant cytotrophoblasts, the mononuclear forms, and syncytial trophoblasts, which are multinucleated. You'll have abundant hemorrhage and necrosis, very elevated serum HCG. Yolk sac tumor, think pink color. It has various architecture. Most common is reticular. Look for those Schiller-Duval bodies if you can find them. Elevated serum AFP. Teratoma, think rainbow. You can have mature and immature. You can have monodermal teratomas. And then small cell carcinoma of the ovary, hypercalcemic type. Diffuse WT1, SMARCA4 mutation, very aggressive, associated with perineoplastic hypercalcemia. Small cell carcinoma, pulmonary type, it's like the lung. Older woman, often bilateral with extra ovarian spread, has salt and pepper chromatin and molding, lots of mites and apoptotic bodies, poor prognosis. Gonadoblastoma, predominantly in young women with gonadal dysgenesis. The sex cord component will be scatat-like with nests with hyalinized basement membranes. Germ cell component, often dysgerminoma like germ cell neoplasia in situ. Good prognosis. Adnexal tumors or lesions, Walther's rest, adrenocortical remnants, paratubal cysts. If greater than 1 centimeter, it's serous cystadenoma. Reactive inflammatory changes include salpingitis, isthmica nodosa, and tubo-ovarian abscess. Wolffian tumor or fat woe, often in adnexa, but distinct from ovary, especially broad ligament and variable patterns. It's positive for cytokeratins, vimentin, androgen receptors, CD10 luminal, plus or minus sex cord stromal markers, and negative for ER, EMA, GATA3, PAX8, and TTF1, in contrast to Mesonephric-like carcinoma. Miscellaneous tumors, leiomyoma, adenomatoid tumor, papillary cystadenoma, and high-grade serous carcinoma. The precursor is stick. And you'll see no cilia, prominent nucleoli, high NC ratio, P53 mutant, and Ki67 greater than 10%. Well, thank you so much for listening, and we'll catch you on the next episode of Pathagonia. Bye.